Luther College professor Maryna Bazylevych Nading will speak about the intersections between health disparities and racism and the overarching concept of social determinants of health. Dr. Maryna has been a professor in the anthropology department and women and gender studies program since 2010, focusing on the topics of medical anthropology, body and health, and post-socialism. Please send a warm welcome to Dr. Maryna as she presents the social determinants of health.
Good morning, everyone. I hope you can hear me well. If not, do let me know. And thank you for inviting me. I have enjoyed visiting some of the UU services in Decorah in the past, and I'm excited to have a chance to be back and see some familiar faces, even if remotely. Today, I will talk about the health disparities at home and abroad, and related to this overarching concept of social determinants of health. Social determinants of health and more material determinants of health or environmental determinants are very interconnected. So they're sometimes hard to disentangle, but hopefully today I can demonstrate some of the ways in which these are, made visible by what sorts of indicators and metrics. So what do I mean by health disparities? It's basically avoidable difference in health status between population groups. You may find some sources referring to it as inequality, more simply. And then when health inequality is considered to be unfair, then this difference is called inequity. And social justice is something that this congregation is very familiar with, but in the health realm, it's the principle that moving towards greater equality in the distribution of income and wealth, opportunities for education and employment, access to health and security, and involvement in civic and political activities is valuable for human flourishing. So one of the key goals of this field of practice and inquiry, global health, is to reduce health disparities by increasing health status of disadvantaged populations. So I'm really proud to be one of the members of the Global Health Board. That's a new program at Luther College. So most people, I think, quite readily appreciate that extreme poverty leads to poor health, right? Just kind of basic calorie intake insufficiencies and sanitation, housing issues, and so on. And indeed, globally, there are some really pronounced disparities. One most obvious one is gap in life expectancy. So it's actually a 36-year gap in life expectancy between countries at its most extreme. So if you were to compare someone born in Malawi, let's say, they can expect to live for just about 47 years compared to someone who's born in Japan, likely to live at least 83 years or even more. Some other pretty kind of clear health disparities globally are just number of children who die before their 5th birthday. About 21,000 children die before their 5th birthday from preventable causes. And then within nations, right, there are also disparities where a child in the poorest 20% of the households is nearly twice as likely to experience that early death compared to the richest 20% of their own community. The number of people who live in hunger is also pretty dramatic, and it's actually the highest on record. It's sometimes hard to imagine that, but over 1 billion people live in hunger. And then health-related expenses that are catastrophic, that either impoverish the family and kind of draw them below the poverty line or bankrupt them, is about 100 million. So some of these kind of obvious global health disparities are pretty pronounced. But then also, and this is what I will be focusing on today, there are significant gaps in health outcomes within countries. So perhaps fewer people are kind of aware of that aspect of it, that, our health is compromised by some inequalities within nations. These inequalities are rooted in differences in social status, in income, ethnicity, gender, disability, sexual orientation, and hopefully we can unpack those together. But for example, in the United States, infants born to African American women are anywhere between 1.5 to 3 times more likely to die than infants born to women of other ethnicities. We also know that American men of all ages and ethnic backgrounds are 4 times more likely to die by suicide than females. And for African American men in the US, they are the most likely among all ethnic groups in the US to develop cancer. So the rate is almost 600 per 100,000 population. That's the highest of all ethnic groups. So today, we of course live in the middle of a pandemic that makes some of these health disparities more visible. So I just wanted to show this map, just a screenshot of today's statistics. Then I'm going to go into a lot of detail about this. This is from Johns Hopkins University, and they report 37 million confirmed cases of COVID-19, including over 1 million deaths worldwide, and 8 million of those are in the US, with about 200,000 deaths. So the reason I brought it up is that if we just look at age-adjusted hospitalization rates among ethnic minority groups in the US, so Native American, African American, Hispanic people, according to CDC, those are the highest, right? So compared to white Americans. So if you just look at the most, at one group, and I just thought we could look at the Navajo Nation statistics. I'm sure you are well aware that indigenous population, so Native American reservations in the US have some of the highest rates of COVID-19. And just compare it to Iowa. That's a nice kind of easy comparison. Of course, population size is higher in Iowa. It's 3.17 million compared to Navajo Nation population is just under 200,000 people. But prevalence rate in Navajo Nation is 5 times higher than in Iowa. And cause-specific mortality rate is also much greater at about 5.33 COVID-related deaths per 100,000 population in Navajo Nation compared to only 0.045 COVID-related deaths per 100,000 population in Iowa, right? So this is the problem everywhere, but here you can kind of see how it's distributed unevenly within the same country. So if I were to ask you this question, if we had the chance to be more interactive, which one will tell you more about an individual's health and life chances, their zip code or their genetic code? The answer would be the former, right? The zip code predicts our health in a very significant way. So prior to the pandemic, those same ethnic groups that I just mentioned have also experienced higher rates of, as I mentioned before, infant mortality, some infectious disease like HIV/AIDS, cardiovascular disease, and substantial differences in disease incidence, severity, progression, treatment. So these mortality and morbidity causes are not random, right? They are rooted in the social determinants of health, as I mentioned before. So some additional statistics before we kind of talk about the reasons for it is that, for instance, you can see just self-reported health as actually there's a really good correlation between self-reported health and then also kind of outside measurements. So more African-American, Native American, Latino, and Pacific Islanders report being in poor health or just fair health at any income level. Right. So even if you look at the top percentage in terms of income bracket within those ethnic groups, they report feeling worse. In 2002, there were about 230 excess deaths among African American people per day. So it's preventable deaths, right? Deaths that shouldn't happen, but does occur. If you look at kids, 33% of African American children, 29% of Native American children, and 28% of Latino children live below poverty line as compared to just about under 10% of white kids. So those are also connected to then their health outcomes. And 3 more pieces of statistics for HIV infection rates. This is other forgotten epidemic, right? That's been replaced by a new plague. But, the rates of HIV infection have doubled for African-American people, and they remain stable among whites. So again, thinking about what are the reasons that are driving those numbers up. We also know that racial segregation in many American cities is comparable to that in South Africa during apartheid. Let's see here. And we also know that for African-American women of any class, any socioeconomic status or class, who reported high levels of experience with racial discrimination. They were nearly 5 times as likely to deliver underweight babies, which again has kind of lifelong health consequences for those individuals, as those who reported no experience of racial discrimination. So this could be endless. I could kind of go over the statistics forever and ever. One of the things in the sources that I will share with everyone, if you're interested to learn more, is Kelly report. So in 2015, there was an effort to kind of put these into more readable format for everyone to be able to educate themselves and see some of these numbers by specific either cause of death or just morbidity statistic. So if you just look at this one chart that I included here, and if you look at homicide rates, that's the bottom row. If you look at the 2013 and comparison between white and black people in this country, then you can see that the rate is especially high for black males, right? And it's so much higher than any other grouping here on this chart. So there is a lot. Some of these health disparities are extremely obvious, right, when we look at that. So overall, I have to say, though, that life expectancy and health outcomes in many populations have improved. If you look at it again on the population level without, kind of paying a lot of attention to those groupings within the nations, overall, the health outcomes have improved, but the innovations in how we approach health and also in things that prevent us from getting sick to begin with have not been distributed evenly. So nearly everywhere in the world, wherever you look, any country, you'll see this, what we call social gradient. And social gradient means that if you look in the population, as income increases, life expectancy increases, and also morbidity decreases. So people's experience of ill health also goes down. So it's kind of stepwise improvements in life expectancy is evident as income increases. Wealthy people live longer, healthier lives than do middle-income people in the same country, who in turn live longer and healthier lives than poor people in that same country. So one chart that I included here that might be kind of nice one to look at compares 5 different countries. So if you look at the kind of how clear this under 5 mortality rate per 100,000 live births by level of household wealth, you can kind of easily see that gradient, right? So looking at the poorest people in any of these countries, this dark color bar, you can see how much higher that under 5 mortality rate is, compared to people who are the richest in those same communities. So I mentioned before that in the US is not represented in this particular graph, but in the US, the death rates for white men, for instance, are twice as high in the low-income zip codes as they are in the high-income zip codes. And this gradient that you see here on this screen is actually really steep, is especially steep in countries that have pronounced inequalities, like the United States, where the gap between the rich and the poor is especially wide. Okay, so why do we see this social gradient everywhere in the world, including the US? I mentioned before that it's really a combination of environmental and social determinants of health. They are really interconnected, but we know that the answer is likely rooted in how a person is experiencing their socioeconomic status and what are the policy measures, how the society is organized in ways that it can either mitigate that social status of an individual or not. Can the society catch them, people who are in the lower socioeconomic bracket or not? So the notion of socioeconomic status, it's kind of hard to, it doesn't have one definition, but it's basically in reference to an individual's standing in a society based on individual and household income, education, gender, occupation, ethnicity, and race, and other characteristics that are salient for that particular society, right? For that particular social, cultural, political, and policy environment. And I included here one table that's not very easy to see. I tried to scan it in color, called the Progress Plus Framework for the Social Determinants of Health, that attempts to summarize the ways to talk about the social determinants of health. So there is no one measure of socioeconomic status, but these are other proxies, right? So if we look at, within each, then we can kind of tell. So place of residence sometimes is a good predictor. Race, ethnicity, cultural language, occupation and employment status, gender and sex, religion, education, socioeconomic position, social capital. So kind of neighborhood, community, family support, and other aspects of social relationships and networks. So if we kind of look at one's ownership of various assets, amount of type of education, type of job, residential area, other characteristics that can be used to evaluate a person's relative position in a community or a larger population group is what we call these social determinants. I'll move forward a little bit. Do you know how much time I have, Carolyn, left?
Yeah, you're doing really great. It's 10:46, and
Okay.
If you want 5 minutes of conversation, you've got like 4 minutes to talk and then break to conversation.
Okay. So I'll move here a little bit kind of to talk about race more specifically, because I just so far have been mentioning this wealth health gradient, right? But obviously income is not the only factor that impacts health outcomes. Another prominent one is race. Gender is also a really prominent one, but I'll just mention race a bit. And so from anthropology, we know race is not a valid biological category, but it is a very valid social category, right? It's a very important social category. Many people believe that the word race is a scientific term. This is not the case. It's a result of kind of ideologies of race that have been circulating here and elsewhere for hundreds of years. Human biologists have shown that you can't really define one in terms of race by phenotype or genotype, but the rule of hypodescent, for example, in the US is one indication of how social construction of race is so salient. I always show this picture in anthropology class because it's very obvious demonstration of this rule of hypodescent, where you see Barack Obama as a child with his mother, and clear assignment of this individual to the category of an African American, despite the fact that he is just as white as he is black. But basically, race affects health outcomes because of its importance as a social category. So it's been used as a rationalization for patterns of exploitation, slavery, socioeconomic injustice, in other words, racism. And it has real biological consequences for people. So I will talk about those real biological consequences for people just using an example of a classic study conducted in Harlem in 1990. But before I go there, I just wanted to kind of clarify that there are different kinds of racism, and all of them operate together to create these this pattern of exploitation that's so harmful for one's health. It could be in the most obvious kind of individual racism realm, just personal prejudices. So one might experience it if they are the target, either as microaggression or direct violence, right? And in a number of other ways. But also, and even more important for people who look at the population level, is institutional racism, because institutional racism is basically this invisible, oftentimes invisible, structural violence that predisposes one to health risks that become then evident in their bodies. So patterns by which racial inequality is structured through key cultural institutions, policies, and systems. So examples of it are in education, healthcare, housing, law enforcement. Most recently, we've seen a lot of that, unfortunately, and the legal system too. And then these are usually upheld by harmful and flawed racial ideologies. So oftentimes, basically, victims are blamed, right, for their own poor health, either through behavioral choices or even, incorrect assumptions about genotypes and predisposition to certain risks and so on. So this is this piece of statistic that I wanted to show you. It's from the 1990s article on basically looking at two populations. Here you can see one population of life, you're comparing life expectancies here in Bangladesh and in the US. And in Bangladesh, it's a meth lab, one particular, town, and Harlem in New York. So you can kind of see that childhood mortality was higher in Bangladesh, but men in Bangladesh were more likely than men in Harlem to be alive after the age of 40. And so the death rates in Harlem were so high in large part because of the cardiovascular disease. But, basically the goal here of this article was to demonstrate in a kind of clear way, using one particular case, that socioeconomic gradient, because of the socioeconomic gradient, it cannot be assumed that someone in a rich country will necessarily be in better health than someone in a poor country. Right here, you can see that pretty clearly. So I mentioned this before, that this high mortality rate for men in Harlem at that time was due to cardiovascular disease. But why, right? Why do they have this high rate of cardiovascular disease? So there are many explanations, but one comes from studies in humans and other primates and mammals, demonstrating that being in lower social status leads to much higher stress levels, and this contributes to chronic disease. So lack of respect and autonomy is very stressful. Chronic stress takes significant toll on body. So thousands of small stresses and large stresses accumulate. They don't just dissipate, right? They're relentless. And other factors too contribute to quality of human environments, all right? So where one lives, how much green space they have, how much control over their own destiny one feels they have. Food systems, can they ensure that their children are safe? All of these things kind of work together. So I mentioned already kind of structural violence as a concept. So I'm not going to go over all of it since we are kind of short on time at this point, and I'd rather leave some time for questions and answer. But it's important to kind of remember that cultural explanations of health disparities can cover up structural violence. And it's very dangerous, right? That people can kind of resort to just saying, oh, well, risk rates for diabetes have always been higher for African Americans or for indigenous peoples. But it's very important to then kind of dig further and ask, well, why is that? Is that random? Is it not? It's not random. So inequalities can be considered macroparasites, right? Because they are disease-causing agents. So it's extremely important to look at them. But a message of hope is that because they are a product of human social structures, we can actually change those social structures that create this disease-causing agents. So that's a very hopeful message, I think, ultimately. When people have more power to make choices in their lives, they are likely to have better health outcomes. And there is a lot of evidence of that for us to kind of hold on to. So we have common interests, and I think just global solidarity is really, really important. I will finish with this slide. I had a couple more, but I'll finish with this slide where I am channeling one of the very prominent figures in the field of global health, a physician, but also an anthropologist and just generally advocate, Paul Farmer, who basically stresses that perhaps this is our marker of civilization, right, is lessening suffering. And, maybe we can all imagine it as a quest of modernity. So this kind of relates back to the message that was read earlier in the service. So I'll just stop here and thank you for listening and thank you for your time. There are many, many potential sources that you can explore. Some of them were used in this presentation. Others I did not get to use, but at least I will mention them here and you can keep looking on your own time. Thank you.
Thank you, Maryna. Yes, and we can share all of those excellent video and web resources in our newsletter. So that looks like a real bounty of excellent reading and viewing. And thank you so much for this talk today. So much information. It's like we should make a whole documentary about just this topic and dig in really, really deeply. So if anybody has questions or comments that have come up, please go ahead and raise your hand. And actually, we are pretty small, so you can probably just unmute if you want to respond or reflect on some of this important information. For me, some things that really stood out were the facts, frankly. I think I know that there's inequality, but the fact that African American babies are 3 times more likely to not survive is heart-wrenching and heartbreaking. And then also just how you closed in talking about the impacts of stress and how that comes from so many directions. And that's really the underlying determinant of these health issues for special groups.
Absolutely. And I should also say that every time that we discuss health disparities domestically in class, at Luther, either in medical anthropology class or in global health class or in public health class, I can really see, students are shocked. I feel like they don't, now we hear more about this with the pandemic. But, prior to that, just rarely kind of discussed statistics, and they're pretty shocked to find out that U.S. doesn't fare well in comparison to almost any other industrialized, post-industrial nation in many, many health indicators, precisely because of kind of inequalities. And not just healthcare system per se, right? Because healthcare system helps people after they get sick, but it's not something that causes ill health to begin with.
I cannot raise my hand, but I'm gonna. Hello. So this is Karen again. I just wanted to note I'd written in the chat another resource that I happen to know about because I work at Emory University is covid19.emory.edu. And if you go there's a map of the entire United States, but you can drill down by state and you can really see some of the inequity that's happening here. Like in Iowa, the white bar is much smaller than the African American bar and the Asian bar, even though in our wider population, the white bar is much bigger than any other race or ethnicity group. And our neighbors in South Dakota, it's even more obvious, that disparity. You can see what Maryna was talking about with the indigenous population, how it's nearly twice that number of COVID cases compared to the white population. And then the Black population is twice the number of the indigenous population. So I encourage folks to look at some of these online resources, and it becomes really apparent really quickly when you look.
Thanks, Karen. Does anybody else have a thought or reflection or question?
Hi, this is Sue Adi. I just wanted to thank you, Maryna, for your talk. And I especially like it that now more and more when we see comparisons, they aren't comparisons about other poor countries and the great United States and its wonderful life expectancies. And so I really enjoyed it when you talked about Japan having this 84, I think it was, life expectancy compared to Malawi being in the 40s. So I think we need to see more of those statistics showing that we are no longer the country that we thought we were as far as being excelling in all these markers of health. Mm-hmm. So thank you for that.
Yeah, thank you. Absolutely. I think the last time that the U.S. fared well compared to other countries as far as overall health indicators and distribution of good health was like 60s or 70s. And since then, it has been decreasing, for both just status of health and life expectancy. And so, of course, if you're a historian, which I'm not, but you can think back like what was happening in this country in the 60s and 70s. There was a lot, that gave people a good hope, right? So I think that not underestimating. People shouldn't just be worried about like unhealthy behavior. They should want to have healthy behavior towards some goal, right? So we can't expect people to care much about their health, if they don't see ultimately what it's going to be for, right? So it's not just about trying to change somebody's individual behavior. I think people often think of it in terms of like smoking rates, or whatever, teenage pregnancy. All of these things are just kind of incidental in the grand scheme of things.